So thank you guys for coming. Some of you are here to do a refresher training. Some of you are here to get access into our Coordinated Entry Access Point EDA. Either way, we're going to do a robust training so everybody's all on the same page when we leave today. So let's just jump into it. The first step of coordinated entry is diversion. Diversion, diversion, diversion. This is always your first step. This should be everybody's first conversation. When we are working with our clients, we need to remember that our system does not have the capacity to meet the need of every homeless client and every at risk of homelessness client that we have identified in the system. It's the reality of the situation. We don't have the affordable housing stock and we don't have the financial assistance. This is a nationwide issue, I'm sure all of you are aware of. So the best way to prevent and end literal homelessness is to divert clients from entering the system if at all possible. So diversion is a strategy that prevents homelessness for people seeking shelter by helping them identify immediate alternative housing arrangements and, if necessary, connecting them with services and financial assistance to help them return to permanent housing. So anyone can do diversion. It's more effective and more appropriate use of shelter resources. It reduces the strain on the homeless response system. It can help people avoid a very stressful homeless episode. And diversion, the idea is to pair creative brainstorming with minimal or no financial assistance so people can avoid entering the homeless response system entirely. So when we're talking about anyone in the homeless response system can do diversion, we mean anyone. We should all be having this conversation. I don't provide direct client services, but when we have clients call and I get the chance to speak with them, I'm always asking those questions. Where did you stay last night? How long have you been in this location? And are you safe staying there? We want to make sure we're asking these questions, and then based on the response, you can really tailor the client's response. You can tailor your response to appropriately meet their needs. So clients who are identifying as having a safe place to stay, but maybe it's inconvenient for them at this time, we should be giving the realistic picture of what homelessness looks like in our community. Homelessness is not glamorous, as we all know that are on this call. Many of you work in the shelter. We've got Brian Scott and Brian Overby. You guys are from the shelter. Lucy, Nick, you guys do that street outreach, we're talking our clients that are literally homeless on the streets. And Carmen and Ursula, you guys meet with clients on a variety of different levels. You know, you might have clients coming in through Open Door, or maybe they're coming in for some type of financial assistance to get into housing, whatever the case may be. We're all meeting clients at different entry points, but we all should be having this very similar conversation, explaining that homelessness is there. We have this coordinated entry system, and homelessness and how we approach it and connect clients to resources is by triaging clients to ensure that those that are the hardest to serve are served first, that those that have been literally homeless in our community and have the highest needs and the highest level of care, that those clients are being engaged with so they don't die literally homeless on our streets. Those clients are those clients that need a person to advocate on their behalf to get them connected to these housing intervention services. Like it says here, it's more effective and appropriate use of shelter resources. We are fortunate in the continuum to have two individual emergency shelter resources. We, of course, have other family resources for shelter, but our individual shelters, the Salvation Army Sarasota and Salvation Army Manatee, we have resources there, but we still should be painting a very realistic picture, especially in Manatee County, when there are substantially fewer amount of beds for clients to be able to stay at, as opposed to the Salvation Army Sarasota. We need to be depicting that reality, and that, entering the shelter, oftentimes we might have an overnight stay, but at 9 a.m. you're back out on the streets. So are you sure? Are you ready to enter the homeless crisis response system? Having those conversations with the clients. Like it says here, it reduces the strain on the homeless response system. We have to keep in mind that, the more clients that we have entering into the system, we have to continue to monitor and manage and ensure that those clients are connected to housing intervention services eventually. And as you all know, that homelessness is not, like I said before, it's not glamorous. When we're having these realistic problem-solving conversations with clients, we should be painting that picture of the reality of homelessness. Yes, you may stay at the overnight shelter, or if we're in a family situation, the family shelter, but there's time limitations. There's costs involved. Neither Salvation Army allows clients to stay overnight for free. You might get a couple nights of free stays, but past that, there is a cost associated with staying in a shelter. Without that shelter stay, you're literally homeless on the streets. And what does that look like for the client? So when we're talking about brainstorming, it's what other resources can we provide, or what other resources does the client already have that they may not necessarily be thinking of? Because most of the time, clients that are entering the system for the first time, we're in that crisis mode where, like, I'm going to end up homeless. I don't know what's going to happen. So a lot of times it's having that conversation with the client to kind of slow down that crisis process, or that crisis thought process, so that they can look for the other resources that they might already have, whether that be family or friends or coworkers or whatever the case may be. So they can explore that as an opportunity to prevent their homelessness before it even begins. So how do we divert clients from homelessness? Well, these 3 questions really are going to be your driving force, and those responses are going to help you connect that client and connect those dots. Where did you stay last night? How long have you been there, and are you safe staying there? By asking these 3 questions, we are able to guide that conversation. Clients that are in a safe place that provides shelter and is not a public or private place not meant for habitation, we want to ask more questions and divert the client back to that location. So if a client was staying at their mom's house last night, but she's kicking me out today, well, what does that look like? Is there a way that we can connect with your mother and talk with your mom so that your family doesn't enter the literal homeless situation? Is that something that we can provide limited case management? Maybe it's that the client needs childcare and all it takes is a referral. We've had so much homelessness prevented and diverted with very, very minimal case management. And oftentimes clients, they just need a little hands up, to get connected to those resources that we may have already in our toolbox. Clients also having that realistic conversation about the by name list. Currently, we have over 300 clients that are listed as active on our community by name list. So when we're talking with clients who are newly homeless, or not even newly homeless, just at risk of homelessness, explaining how the system works for them, explaining that clients that are new to the system, I mean, imagine you're at a deli and you take a number and your number's 360 and they're at number one. They're now serving number one. It's one of those realistic conversations that I've had with clients where we're like, listen, this is the reality. This is how HUD has mandated all homeless crisis response systems operate. It ensures that those clients that are the most vulnerable are connected to those resources, and clients that may be able to self-resolve are able to do that on their own. So that capacity fills up for those other clients. Like it says here, clients who have a safe place to stay will not be referred to housing intervention services. We cannot operate within a system that has clients coming through that are not literally homeless. It's the way HUD has designed the coordinated entry system, and we are required to implement those best practices at this level. So if a client were to answer a literal homeless situation, we want to ask again more questions. And when we hear dates that are new or that clients are coming from out of town, we're going back to that realistic conversation and realistic and realities of the homeless crisis response system. Clients who enter new to homelessness, meaning that they have been homeless for less than a month, having that same deli analogy conversation where, we are able to provide you this coordinated entry intake, but please keep in mind that we are working off a triage system. And a lot of times when you listen to other trainings on coordinated entry, they use analogies of being in a hospital room and someone coming into an emergency room with, their arm chopped off and bleeding out, and then somebody with a migraine or a headache. We have to triage those clients so that the ones that really need the most help are connected efficiently and met with the need that they have. Same with clients that come from out of town. When clients come from out of town into our community, there will be data that we will go over in the live site, but clients coming from out of town, their homelessness begins at the date of creation in our system or the date in which they are reporting to you, whichever is later. There is a reputation that is built amongst communities where if you show up in their community, you can get services. And we have, as all of you on this call know, we have enough of our own literally homeless clients in Sarasota and Manatee County. We cannot encourage clients and a reputation of serving clients that come from out of town. So when we are creating clients that are coming from out of town, their approximate date homelessness started will always be the date in which that they are created in our system, or the date that they tell you they're homeless, whichever is later. We cannot verify homelessness in our continuum of care from anything previous to their date of creation. So if a client comes in to the shelter or comes in to do a coordinated entry intake at Turning Points, and Turning Points has never met with this client, they've never served the client an open door or anything like that, and we're creating the client's profile to give them an access point, that is their approximate date homelessness started. And for those that are new to the system, we'll go over and that will make some more sense when we're in the live site. But that date is important because we can't take any historical previous instances without proof in our COC. We have to see that this client was active in, Sarasota before they came to Manatee, something along those lines. Just keep that in mind. as we go on. And I'll give you some more examples when we're in the live site. But this is just all honestly to deter clients from coming to our continuum of care literally homeless. We, like I said before, I'm sure all of you can attest to seeing our clients that are from our area. We must serve them first. They are our, neighbors and our unhoused neighbors, and we cannot set this tone that we are going to just, oh, you were homeless in California, go to Sarasota, they'll house you. I don't think any of us want that kind of, we want to make sure that we are focusing on our clients that have the longest history of homelessness in our continuum first. And like it says here, having these real conversations, it may not feel like you're helping them, but in reality, you are. This conversation that you have with the client, it really can divert them from the homeless response system entirely. Having realistic conversations with clients to explain the scenario, or explain the system, and explain how their only solution is most likely self-resolving, it will get those, wheels turning. Okay, well, they're not going to help me. What else can I do? I know it feels sometimes when we're having these diversion conversations that you aren't helping, but it is helping the client and the system. Otherwise, telling them that, oh yeah, we have a list, you just have to wait on it. Well, that's giving someone false hope, because that list is over 300 people long, and we only have enough housing and enough resources for maybe a third of that list annually. Everybody else, we have to figure out very creative solutions for these clients, whether that be with vouchers or with bus tickets back home, or, just even returning back from where they came at mom's house, whatever the situation may be. But having that honest conversation will help the client, especially if they are coming from out of town or are newly homeless. Does anybody have any questions when we talk about diversion or anything like that? You guys can chat or you can raise your hand. Okay. I am going to ask it after two more slides, about a diversion story. If you have any, just to give you guys a heads up. I have quite a few diversion stories, and I don't even do diversion. So I'd love to hear from you guys that have been working in the system, maybe a successful diversion story that you have, either collaborating with another agency, or maybe it was just having an honest conversation and the client not entering into our system because of that honest conversation. So when we're talking about the diversion process, we always want to ask the client if it's safe for them to return where they stayed last night. We can support the client in contacting the family or friend who is asking the client to leave the situation and negotiate for that client's return to that housing option. Again, this is an excellent time to explain to that person, along with the client, the realities of entering the homeless response system. I'm sure Nick can attest to many youth situations in which the client, youth may, as we all were when we were younger, maybe not all of us, but get frustrated with having to follow mom and dad's rules. But then when they're met with homelessness, the rules are the same as mom and dad's. You just now don't have a house you don't have any shelter over your head. And always keeping in mind the client's safety. If clients are safe to return to that place, can the issues that are preventing the person from returning be resolved with financial assistance, case management, mediation, or other short-term assistance? Identify solutions to assist with diversion. Move forward with the applicant returning to housing. That is the best outcome for this, is to have the client return to where they once were. So from there, the best way to end a client's homelessness is to divert them from the system entirely. So with this slide, do you guys have any recommendations, or do you have any case studies that you've experienced a positive outcome from a diversion conversation? Feel free to mute, unmute.
Well, we've had a bunch of these down here. From people, from behavior specialists from Fort Myers, north of Tampa, you know, they discharge them and they put them in a Uber cab, drop them off down here. Once they get down here, it's like, okay, you don't want to become a 9th and Central resident. So, you know, sometimes keeping them and showing them what an overnight shelter looks like, and then waking them up at 4:30, putting them back on the street till the next night. And once they see it, what realities kind of look like, some of them, they start listening. But before COVID, they used to have the people come down and they'd catch you at the gas station. We have this petition to sign. Well, they'd promise people from all over the country to come down here, sign these petitions, and then they'd get trapped living in hotels and couldn't get home, where we would, you know, find the bus tickets and get them home.
Mm-hmm.
So, but yeah, as soon as they see what it looks like and that it's not a dorm room, or you come down here and get a bunk and you get 30 days, 60 days to figure it out, you know, things change rapidly.
Absolutely. We go from I have nowhere else to go to, well, maybe I do.
Exactly.
Nick, diversion is a huge part of your job. Do you have any recommendations to anybody on the call? Oh.
How you doing, Lauren? I'm
Thanks.
Ed, and I hear what was going on, but I had pre-scheduled a call, so I'm trying to be at the same time. All right, so I will. Brian, definitely get back with me, and we can sit down and talk more. Sorry, I should be done in a second. I'm sorry,
You're
Lauren.
fine.
I'll get right back in it.
You're fine, Doc. No, I know just from Nick's working with Nick and his ability, honestly, his ability to just give the realistic story and realistic situation with clients. Turning Points, do you guys have any stories of success? Or Lucy at Centerstone, any diversion stories where you know that, you know, it was having a conversation, or maybe even just providing a referral to another agency where that diverted the client from the system?
All right, Avery's listening too. We're using one computer, so he's with me here. We do get a lot of phone calls from people out of state wanting to move over here. And of course, we tell them the prices of a 1-bedroom. We tell them to think about it. So
that's always a huge deterrent. That's why I moved out of Sarasota County. I live in Pinellas because, you know,
yeah.
Even for myself, if I were to be living on my own, Pinellas is pricing me out at this point. You know, if you want to live in the Sun Coast, better be ready to pay for those that price. That cost of living definitely can keep a lot of people from entering the homeless response system for sure. When clients call, having that conversation at least before they show up, that gives you the opportunity. Doesn't always work out, but at least you've done what you could. Yeah, thank you. I'm gonna go on. So what outcomes of diversion? What does a success look like? It can be a temporary or permanent housing solution outside of the homeless response system. It can be permanent housing of their own that maybe they figured out, viable, safe, and shared housing with family or friends. Maybe it's temporary housing with a plan for permanency. Either way, the overall goal is to utilize diversion principles and skills often and whenever possible to decrease people's length of time homeless and open capacity in other homeless resources. So why coordinated entry? Well, all of this pretty much means because HUD told us to. Back in 2014, there was a COC program interim rule created for COCs to establish a centralized or coordinated assessment system. The whole goal of having a coordinated entry system is to promote client-centeredness. Every client is different. Every story is different. Not all homelessness is not the same. That is for sure. We want to prioritize most vulnerable for available housing and services. When I first started, I'm not sure, some of you have been on board for a while. When I first started in 2017 and doing rapid rehousing monitoring and invoicing, there were a lot of clients who definitely were not the hardest to serve. Some clients who had no homeless history at all were receiving rapid rehousing subsidies. And sure, it was definitely easier, but like one of my favorite sayings is easy is not always best. Easier is not always better. The way we prioritize clients is to look at each of the records and each of the access point intakes that you guys create and triage it so that those that are homeless the longest have the highest level of care, and determined by and looking at their VI SPDAT to connect them with the appropriate housing resources. When we have clients who have very little homeless history in our system, those clients are those same clients that we're looking at, a huge chunk of our population really is a self-resolve situation. Clients with very little homeless experience in our system, we want to be able to house those clients who have been homeless the longest, and it's not by choice. I mean, we should be, of course, but it is federally mandated that we house those clients that are hardest to serve. So that shows the system that client, I don't know if you guys have ever, driven by a client. When I first started in 2017, I would drive by on 17th Street and 301. There was always this gentleman. And this, when I first started at Suncoast, and this gentleman was out there all the time, every time. And you'd wonder, well, why is this man still out here? He's obviously literally homeless. He's on, it appears just from my car that there was some mental health going on. What's going on? Why isn't this client being served? And that's what the federal government was seeing, was that all of these clients, our numbers for PIT count were not going down. The average number of homeless clients in a continuum of care, those numbers were not decreasing. They were not being impacted because the same clients that you would see every day, nobody was going out and engaging with them and offering them the services they so desperately needed. And the clients weren't advocating for themselves. Maybe they had at one time, but you give up on a system if you continue to have doors slammed in your face. So with Housing First and the coordinated entry mandate, the system said, hey, we're going to house those that are the hardest to serve, and we're going to put them into housing regardless of the barriers they have. We will work on those after we house them. And from that, we have seen a substantial impact on our literally homeless clients. It also standardized the access and assessment process. We want to make sure that every access point is conducting the access point in a very similar manner. Of course, questions are, if I ask a question one way, it's assumed that the same question can be asked by somebody else, but maybe interpreted a different way. So there is still some kind of, just like standardized assessment tests, there's some kind of ebb and flow that we're working through to look at the process and how to make it more standardized than it already is. But in reality, all of you guys on this call, your intakes are all the same. Nobody's asking any more questions or any less questions than anybody else. You guys all have the same intake, and you're ideally collecting data in the same manner. Like it says here, it creates a low barrier for access to housing interventions. That's that housing first. That's that, you know, we don't need you to be sober to get into housing. We don't need you to have an income to get into housing. It would definitely help you maintain that housing and stabilize in your own life and ensure housing stability, but it's not a barrier to entry. And then, as always, we are always trying to improve. Just like I said, we know that there's some issues within the VI SPDAT specifically that other continuums of care have found, but we always want to try and improve the process for our access points so that we are providing a very, very standardized approach to collecting this data on our clients, so that clients aren't treated any differently at any entry point. So anytime you guys have any recommendations for improving the coordinated entry system, feel free to send them to me. Feel free to discuss them with your supervisor, who can bring them to our coordinated entry call that we have with your program leaders. We're always looking for improvements. You know, we're always looking to do things in the best interest of the clients. And because you guys are doing the boots on the ground work and collecting this information, let us know how it can be better. Please, I'm all about process improvements. So we look at this little graph, and we have clients that over here without the coordinated entry system. I mean, there's clients everywhere. We've got this guy up here. He doesn't know what he's doing. They're all trying to enter through this same system, but nobody knows how to get anywhere. It's like, what's going on? I had one case manager tell me that he had been working in the system since 2012, and prior to coordinated entry, he had no idea how clients got referred to housing. So you could imagine the frustration on our literally homeless and long-term homeless clients' parts. If a case manager who works within the system had no idea how to get connected to housing, what luck were we going to have with the 10-year veteran who's been homeless on the street for, you know, the last 10 years? So this is what our system looks like now with coordinated entry system. Clients come through the same door, your doors, whether that door be Turning Points or Salvation Army Sarasota, Centerstone, Suncoast Partnership. I think that's everybody. You guys were all providing the same assessment. We're all asking the same questions with the client, and then we're triaging them, and we're assigning them with client choices. Ideally, we would have a multitude of rapid rehousing projects to choose from, a plethora of permanent supportive housing placement options for clients, so we could say, hey, here are your options. But the reality is we don't. So when we're talking about assigning clients with choices, we are still assigning them with choices of rental unit offers on that rapid rehousing side, or maybe different types of permanent supportive housing or different intensities of permanent supportive housing. But choices often are limited because of capacity. Either way, it creates more of a concrete flow for clients to enter the system, be triaged, and then connected to the appropriate intervention service. These are our access point locations. Harvest House is also on this list. I honestly haven't updated it just yet. And your hours of op and Centerstone. Thank you, Lucy and Avery. They just joined in January, I believe. So thank you guys. You do Centerstone outreach, and your access points, I would believe, will be roaming as you connect with clients when you do outreach. From here, we are going to log into Service Point. I'm actually going to hop up and grab another drink because I didn't get one. So let's just give, if anybody has a bathroom break necessary, let's give us 3 minutes to take a second so I can grab a drink because I am pregnant and dying of thirst. And I'm going to play the pregnancy card. Thank you guys. Give me 1 second. Did anybody step away? Does anybody need a minute? Because I can continue. I apologize for that. Okay, so let's just give it a minute. Maybe some of you stepped away for a second. Okay, thank you, everyone. Let us continue. Oop. Ursula and Carmen, are you on the call?
I am now.
Okay.
I got kicked out, but I just got taken out a few seconds ago.
Okay, great. Just making sure. All right, so let's jump back into the live site. After you guys complete training today, and if you don't already, you will have access to our coordinated entry intake form. So we're going to log in. So the first thing we ask ourselves when we log into CSIS, what am I doing in here, right? What am I doing? Who knows? Well, today we are collecting information on a client, and we are going to enter data as an access point. So all of you should have, after today, if you don't already, you will have your EDA for your access point coordinated entry Suncoast partnership. After training today, you guys will all get your access point intake instructions. As you guys work through and learn the system, please use this document step by step by step by step. It is literally, if you follow every step on here, you are able to do this and make sure that we're answering questions, answering all the questions to the best of your abilities. So you will get this information after our training along with the PowerPoint and this recording. So from here, we're going to access point EDA. We don't typically backdate because your coordinated entry intakes should be done live and with the client. So the first thing we want to do is client point, and we always search for our client. As you all know, we have many clients in the system, and a lot of clients that have a history of homelessness, they will already exist in our system. So we're going to do Brandon Test. Good old Brandon Test today. And we search for Brandon here. Please, in your searches, if you ever come up with multiple clients that you can identify as having multiple profiles, a client with multiple profiles, please just send me their client ID so I can merge them. So if this client had the same information, you would simply send me an email with the two client IDs and say client merge, and I will merge them into one client's information. That ensures that we only have one client profile for each client in our system. It'll keep all of that historical data that exists on a client profile, as well as combined with the new information. So keeping that in mind, please do that. We're going to use this Brandon test, 120889. You guys feel free to use this client to test things on, but also feel free to use our training site. Your training site I can send also. This will allow you, anything that you enter into this training site, you can not mess up, essentially. There's nothing that you can enter in here that will affect anything in the live site. So you can create as many bogus clients as you want, provide them all the services in the world, whatever you need to do to learn. I highly recommend it. I encourage you to use this training site and work with it from there. So the first thing that we all need to keep in mind, I cannot stress this enough, our universal releases of information must be added, scanned, and uploaded to the client's CSIS record. We must always look to see that the client has an active universal ROI. So we can click here and review. This client has a bunch, obviously, because he's our training client. But if there is no active universal ROI, we cannot share that information. So please, while you guys are working and conducting these intakes, please ensure that the Suncoast COC universal ROI is scanned and uploaded here. I'll pull up an example. This is our Suncoast ROI. I know some of our agencies have their own ROIs, but for the entire continuum of care, this is the ROI that we need scanned and uploaded. This will allow us to communicate. This is simply saying that the client has agreed to share their information, and that's what we're doing. We cannot discuss client information without this scanned and uploaded to the system. We can't just add it, and we can't take an internal ROI for the use of the entire COC. We have this universal ROI, so the client only needs to sign one universal ROI, and it will be good for the entire COC. So please keep that in mind. So the first thing that we want to look at when we pull up a client's profile is ensure that not only is it added here, that we have that scanned documentation attached to where it was added. So something like this with no attachment, we can't CYA that, cover your agency. You cannot cover your agency with anything other than having it scanned and uploaded here. So we're gonna look real quick. We see that Brandon Test has filled out all this information. He's initialed all of these documents, and our ROI is good for 2 years. So this is a good ROI. Please cover your agency, CYA, and that is the very first step in a successful access point intake, is adding, scanning, and uploading the universal release of information. From there, we can look at the client's entry exit. So oftentimes we can see this client has a long history of homelessness. So when you guys are able to, so say that you are getting scheduled access points and you do intakes on clients based on appointments. Well, maybe you're able to go into the client's CSIS record prior to that appointment to kind of familiarize yourself in the client's history in the COC, right? So if this client had an emergency shelter entry, then we could see that this client, let's just pretend that this is not deleted. I'm going to delete this. Well, we can see that this client had stayed at the emergency shelter. You also want to look for previous access points. If the client has conducted an access point since 10/1/2021 or within the last, so on October 1st, 2021, HUD changed how we're doing access points and whether clients are deleted, or I'm sorry, are removed from the community by name list and how. So if you see that the client has an old access point that's over a year old, coming from like prior to 10/1/2020, you can go ahead and create a new access point. Anything after 10/1/2020, you do not have to create an access point. There are times with clients where maybe their access point is from 2018 and you see that, but maybe the client had self-resolved at one point, or maybe they moved out of county, they were jailed, whatever the case may be. Looking at the client's CSIS record will help you determine whether we should move forward with this intake or not. Clients should not have 2 access points done after 10/1/2020. So if this was a real client, we would not be doing an access point on this client because he's had 3. So keep that in mind. Anything prior to 10/1/2020, you can go ahead and conduct another one, but after, you do not want to. And conducting another one prior to 10/1/2020, that's if there has been like a substantial change in the client's record. Maybe the client was housed and became unhoused, or maybe the client was jailed and is no longer in jail, whatever the case may be. Just take a look at the client's record to determine whether or not you should move forward with the client's access point. If you're moving forward to do an access point, you want to add entry, and only the head of household should be collected for coordinated entry access point intake. So we have Brandon, he's our head of household. This is our provider, and our type is always going to be basic for our clients. So we've got access point, basic, and today's date. We are going to save and continue. Okay. From here, we're going to scroll down. And we always, if any of you guys, most of you guys have done basic skills with me, I cannot emphasize this enough. This data is not your data. If you have not asked this question, you cannot say that this information is true. So we should always ask every question for the client again. Always, always, always. I don't like saying don't trust the data that appears here, but keep in mind that you didn't enter the data that appears here. So if you didn't enter it, then it's best to ask and answer every question that the client is responding to, especially when we're looking at clients that have long histories in homelessness, or maybe they were created a long time ago and nobody's worked on the clients since then. Whatever the case may be, it is just a good rule of thumb to look at this information as historical reference only. We are entering data that is true for today. When we look at our coordinated entry access point intakes, historically, there were major issues with data consistency. So we have data consistency report cards, which some of your agencies regularly run, and we make those corrections. But the data consistency report cards were really brought about because clients that were entering our coordinated entry system, their stories were not being told in a manner that was consistent with the data that was entered into CSIS historically. So for instance, this is a great example. This client is identifying to us that they are literally homeless. So looking at this data right now, this story is telling us that the client is not literally homeless, that the client where they stayed last night was in a rental by client for 1 year or longer. And we know that's not the case because, well, for today, it's not the case because the client has stayed at the emergency shelter the night before and is identifying to us that they are literally homeless. So this is a perfect example as to why data consistency is so important, and to look at every single question on here. Because if we were just to do our access point intake and not review this information and just say, okay, I just have to enter the client into the project, I don't have to really, I don't have to do an interview or anything, do I? So if we were just enter the client into the project, scroll to the bottom, save and exit, we would be doing a disservice to the client because we're not telling the story. We are not ensuring that our information is complete, current, consistent, or correct. We're simply going through the motions. It is so important for you guys as access point intake workers, as you guys are the access point intake workers, to ensure that you are telling the client's story. Because on this side of things and managing the coordinated entry system, we are not working with the clients face to face. We are triaging clients based off of the data that you guys enter. So please keep that in mind when we're entering data and we're collecting this information. This isn't specific to access points at all. This is for the whole COC and every project that you work in. We are relying on your data to tell the story of the client. And yeah, when we look at information like this about housing status and it says category 2, well, this client has identified to us that they are literally homeless. And prior living situation stated, where did you stay last night? Well, at one point, the client was staying in a rental by client. That is not the case anymore. We know the client is in an emergency shelter. And then from there, we ask, how so we're going to stay, let's say, 1 week or more, but less than a month. So from here, this is where we're going to, collect information on the client's history of homelessness and their approximate date homelessness started. So when we're talking to the client and we're interviewing the client, we're asking, when did this instance of homelessness begin? Well, so we know that the client has been staying in an emergency shelter for a month or more, but less than 90 days. We want to make sure that our data makes sense, right? And so the client can report to us that they've been staying in a place not meant for habitation since October of 2020. And then they went to the emergency shelter back in January. One of our street outreach members connected the client to an emergency shelter bed, so the client was able to stay at the shelter. So we're telling that story through our data. We're asking the client, regardless of where they stayed last night, how many times in the last 3 years have you been homeless? And then we're going to respond however the client responds. So we're counting back to 2018. How many times in 2018 were you homeless? Can you remember if you experienced any homelessness in 2018 or any homelessness in 2019 or 20? This will give us this robust idea of the client's previous homeless experience. So this client is going to report that in 2018, they were homeless for like 6 months, 2019, another couple months. And then since October of 2020, they have been homeless. So we just do a little math, 6 months in 2018, and then a couple months in 2019, and then maybe they were stably housed for a while. Maybe they got housed with a rapid rehousing project, or maybe they were in transitional housing. Who knows? Maybe they were staying with family or friends, but now they're homeless again, and that's October, November, and December. So we're at 12 months or more for this client. If we had just gone through the motions and entered this client into the system without updating any of this information, we would have been telling a completely different story than what's recorded here. The story that was previously being told was that the client was more of a homeless prevention client than a literally homeless client with a lengthy history of homelessness in our continuum. So keep that in mind. I cannot stress data consistency enough. I have, since being in the coordinated entry system and reviewing client information since 2017, there are quite a few clients, unfortunately, that have fallen through the cracks because of inconsistent data entry. The reason we started our data consistency report cards was because of that. The system needed to find a way for us to flag these erroneous data entry errors and ensure that the information was collected or corrected prior to adding the clients to the list. There was one client in particular that one of our fellow providers, they were very concerned that this client had not been helped. The client had been staying at a shelter for 3+ years And the coordinated entry system was not helping this client at all, and it must not work. Well, then when we go to look into the client's record and we see the client's living situation was a rental by client with 1 year or more, and their housing status, this was, let me show you, this is exactly what, when we pulled up the record for this client who had a long history of homelessness. He'd been living at the shelter for 3 years. This was the data that was entered for that client's access point. This data does not tell the story of what was happening with that client. And that client did fall through the cracks for a couple months. He has since been housed and has actually remained stably housed since then. But without that person bringing this to our attention, saying the system didn't work, we would have never known that this information was entered erroneously. So please be very mindful when you are collecting this data that we are working with data that can literally change lives. You can literally impact the outcome of a client based on the data that you enter. A lot of times the data entered here can mean housed or not housed with COC funding based on the information that is in this system. So please be very mindful of that. That's my little soapbox on data consistency. Since January, we have been working to send out access point corrections. So if there is any information that's entered for a client's record that maybe doesn't make sense, or there's a couple little things that, like, if we see something, if something like this comes up, this isn't consistent information because we're looking at a client's story that's saying, well, they're coming from an emergency shelter. They've been there for, let's even say, less than 90 days, a couple months. Their homelessness started in October, but their total number of months homeless is more than 12. Well, that just doesn't make sense, right? Because we've got October, November, December, January, February. October, November, December, January, February. That's 5 months. This would make sense. Something like this, or even if the client had a previous history and you want to report that the client previously in 2018-19 had been homeless 7 months, 8 months, or the entire year, whatever the case may be. It's stuff like that that we're working on to identify and ask you to correct before we put the client on the by name list. It's just a very simple way for us to ensure that we are providing the most accurate depiction of the client's story in our COC and on our community by name list so that we can accurately triage that client and connect them to a housing intervention service that could potentially house them. Does anybody have any questions on data consistency while we're in here? I know some of you are brand new and you might be like, I have no idea what any of this means. Some of you have experience where data consistency just has escaped. You're like, what is data? I don't understand. Like, I keep trying to do this and it still doesn't make any sense. Okay. All right, so there are a couple other scenarios I want to walk through when it comes to telling the client's story, and kind of some common missteps that we may that we've seen, and just to keep you guys more aware and mindful as you enter data in the future. So let's look at, say the client was released from jail last night. Well, just looking at this information, did you guys see how that data changed? So let me switch it back and you guys can maybe, so right here we have all these questions, right? Well, when we change, this is called conditional logic. When we change the response, these questions are dependent on the response above. So let's even look, did you stay less than 90 days? So this response says yes, because here we said that the client was 1 month or more, but less than 90 days. If I change it to 90 days or more, but less than a year, do you see what happens here? Or less than 90 days. And then this question gets mistakenly skipped, I think, because you're just not looking, whatever happens, it's just, it pops up and you're not used to it. But this is how we can report if the client was homeless before they went to jail. So on the night before you went to jail, were you on the streets or in emergency shelter? We're going to say yes or no. If we say yes, watch the conditional logic. All of those questions about homelessness appear. If we say no, then we are not able to report on those days. Same thing with, so this is specific to jails and institutions for clients that have stayed less than 90 days. But let's look at a client who's couch surfing. And maybe last night they stayed at their friend's room, apartment, or house. Watch our conditional logic again. Did you stay less than 7 nights? But they were only at their friend's house for like 3 days. 2 to 6 nights. Says yes. And then that same question appears. On the night before, did you stay on the streets emergency shelter? This is dependent. If we say yes, conditional logic appears. We say no. So these are just little things that I've noticed when doing access point intakes and corrections and all of that, where we kind of just miss it. We're going through the motions and whatever happens. So be very mindful of these conditional logic questions, because when we're telling this story, we are not telling the story of a client who's literally homeless. We're telling a story of a client who is at risk of homelessness. Maybe they're entering the shelter tonight. Well, that's when we want to pump the brakes. We want to say, okay, hold on. Have a night of emergency shelter stay and then come back to me for an intake, because we want to make sure that we are able to collect that information on that client. So we can say yes and then report that homelessness. Even if the client had only stayed at their friend's house a couple nights, just these nights, but this is their homeless date, we are still able to record that, because this was not a long-term stay at their friend's house, but something that's over a week. That's it. This is not a client that is literally homeless in our continuum. So those are just a couple of the more tricky responses that I've seen that people have maybe a little bit of confusion or something. I'm not sure. Okay. Does anybody have any questions on conditional logic, prior living situation? Have you guys come into any situations where, you know, you want to tell a story, you want to make sure that we're reporting it correctly? Brian?
Couch surfing is not homeless?
No, so when we're doing couch surfing, we are doing at risk of homelessness. Especially if the client does not have any literal street homelessness. And
they're on the street, they get their check in the beginning of the month, and they go to the hotel for 3 or 4 days, and then they're back out, they're not homeless?
So I mean, you're talking about a client who's staying in a hotel but paid for by themselves.
Yeah, but also a lot of the people down here at the shelter get their checks, you know, disability checks or whatever. They'll pool their money, and on the first of the month, they'll disappear for 3 or 4 days, and they'll go down to Cadillac or one of the places to stay, spend their money, and then they're back out here by the, you know, the 7th or the 10th of the month.
So when we're reporting on those clients and we are conducting access points, we want to make sure we're not manipulating the data or manipulating the the data entry or anything like that, but we are telling that story. So let's tell about a client that was home, that last night they stayed in a hotel paid for by themselves, but they've only been in that location. They don't have, the resources to pay for more than 7 nights. That's when we can tell this story. And then on the night before you went to your hotel, were you literally homeless? But it's once we get into that 7-night stay, that information changes. So it's really about timing when we're working with those clients that have that. And I know you experience that a lot. And thank you for your question. It's about timing those clients, even clients that have a long-term history of homelessness in our continuum, but like they stayed at a hotel last night. They were with somebody else and they stayed at a hotel for a week. We want to make sure that we're catching them at that emergency shelter or place not meant for habitation residence prior living situation, so we can report that data and capture that homeless history. So with those clients, that's 2 to 6 nights. If they've been staying at the hotel for any longer than that and they're paying for it, we want to pump the brakes on that access point, just even a night, so we can get them having that emergency shelter prior living situation.
A lot of times they run out of money and they don't have the $12 to stay, but it's an ongoing thing where, month after month they're usually on the street and they will disappear. It's amazing how many people don't use the services after the first of the month or when that check happens. And then they come back, mid-month, and then the next month, or they might be around. And when they have money, they go to the hotel. They'll pool their money, and then they'll put 3 or 4 or 5 people in a hotel room and, blow through all their money. And then they're back on our streets and wanting free nights in the shelter because they have no money.
Right. Well, it's identifying those clients.
People, because they're the same people over and over and over and over.
Well, if they're the same people over and over, I would recommend, if we already have identified who these clients are, to catch them at that mid-month mark where they have been staying on the streets before. But, and again, we're talking about clients, if they are staying less than a week, then we're still able to capture this information. They're still literally homeless.
They're homeless. They're not at risk of homeless. They're just putting them in a hotel. Anyway, I get it.
Yeah, and I want every client that's experiencing that type of instability, they need to be identified. Those are the clients that need to be identified in our system. But for them to triage them accordingly and identify them accordingly to tell that story, even if it's, the 2nd of the month and on the 31st, they were staying in a place not meant for habitation, this is still that story. We are still collecting that information. They're still literally homeless. It is about timing when it comes to clients. I mean, we have clients that enter transitional housing, like clients at FRS. If we are not having those clients enter our coordinated entry system, and this is not a Suncoast partnership thing, this is like an HMIS HUD program manual thing that all of this data is based on. But we do want to tell that story, right? It's about timing. It's about getting clients entered into the access point in the right time to tell the right story. And if you have identified these clients and they haven't done a coordinated entry intake, I recommend making an appointment with them if they can show up. I'm sure you are very well versed in all of that. I can make appointments all day, but whether they show up, that's a different story, right?
Right.
And letting us know, because we got Nick too. Nick can go out to those hotels if they've only been staying there a couple nights and do a roaming access point and do that outreach with those clients. Just like Lucy and Avery, they can do those access points with the client in the street so we can tell that story. especially if they are clients that have been in our system for a very long time. That sounds like if they can pull their money together for disability, maybe they could pull their money together for a room share, you know what I mean? Or something along those lines. It's a pipe dream, but it's not something that's completely off the table.
Correct. All good.
Okay, so if anybody else, do you guys, Lisa, Avery, Carmen, Ursula, you guys have any questions when it comes to prior living situation and any of this information?
Nope, I think I got it.
Great.
Yeah.
Thank you, Ursula. Awesome. All right. So COVID-19, something very basic question that we're going to ask our clients. We want to make sure that we are collecting this information. This is the only space in our CSIS that we are asking this question. This is the only question. It should be on all of your assessments, regardless of the project entry type, whether it's coordinated entry, emergency shelter, street outreach, homeless prevention, or rapid rehousing. We need you to ask and answer this question. There will be a time where we are asked as a continuum of care to identify how many clients have entered your coordinated entry system because of the COVID-19 pandemic. And this data point is where we will get this answer. So please ask and answer and report accordingly. From here, your current living situation, you are required to add this information. We're going to select add, and then we're going to populate. We are going to say that as of this date, we're going to start, end date, all the same date, the current living situation, the client's at emergency shelter. Maybe last night they stayed at the hotel like Brian was saying, but tonight they're staying in the emergency shelter. From here, your living situation is verified by your agency. And are they going to have to leave their current living situation within 14 days? This is something that's more specific to those at-risk clients that maybe could be diverted from the system. It's a basic yes or no. So with this situation, the client would say no. If the client said yes, then you would ask the corresponding questions below. From here, we're going to save. Now we've updated. The whole goal of this current living situation is for the continuum to be able to track the to follow the movements of the clients so that we can see when they've become housed, unhoused, in emergency shelter, maybe they have a different place to stay, whatever the case may be. But we can see the movements of the client in the system. From there, we're going to see, does the client have a disabling condition? Well, we don't want to just ask that question. We want to hit our HUD verification first. Even there's data here, there's data here. We don't know who asked those questions. We don't know who entered that data. So we are going to ask the questions of the client ourselves and make sure that our data is the most complete, current, consistent, and correct. From here, you can go down the list with the client. Oh, I lost Lucy. Okay. Lucy, I got you in on 2 computers. I'm going to mute you. Okay. So from your HUD verification, we're going to ask the client, just go down the list. Do you suffer from any alcohol abuse, alcohol and drug abuse? Do you have a chronic health condition? Do you have any developmental disorders? Again, drug abuse on its own. Have you been diagnosed with HIV or AIDS? Do you have a mental health problem or a physical health condition? From here, the client will be able to respond either yes or no to each of those types. If we had just relied on the data that was in here, we wouldn't be ensuring that you are telling the complete current story of the client. So maybe this client identifies that they do, in fact, have a physical condition, that yes, they have a chronic health condition. They don't have a mental health disorder, but they do have a physical health condition. So for some of you who have just recently learned the system, when we need to end a mental health disorder or any of these sub-assessments, we want to make sure that we end this record set, right? So we're going to click on the pencil and we add an end date for this record set because we want to make sure that this data still exists in our system for this time period. And when you end data for HUD sub-assessments, that's what these are called, HUD sub-assessments, you always want to end it for the day before. So today is 02/22. We're going to end it for 02/21. This is ending this yes HUD sub-assessment, and we're going to save. From there, the system's saying, hey, there's no answer to this question now. Well, now you're going to say, as of this date, this response is no. Same thing with our physical condition. We are going to end this. We're not just going to change it to a yes, because that's writing on top of somebody else's data. That's like if you had a piece of paper that somebody else had filled out for the client, going back to that piece of paper and scratching over somebody else's information that they have filled out. No, you don't want to do that. You just want to end that no data for the day before. Oh, what did I just do? Oh. There might be multiple record sets in here too, as you can see. And then wait for that to incomplete and then hit yes. And now we can respond to these questions. If yes, is it expected to be long continued, indefinite duration, and substantially impairs the client's ability to live independently? Again, basic yes or no question, either self-attestation on how the client identifies. From here, we're going to save and save and exit. Up here, now we know that yes, the client does have a disabling condition, but we know that because we asked the questions. We know that because that's how the client responded to us. From here, we see a total monthly income amount of $1,300. We want to ask the client, does the client currently make $1,300? Or we're going to HUD verify and then go down the list, asking the client, do you have alimony, child support, earned income? We're going to go down this list to ensure that we are providing the most complete, current, consistent, and correct information. From here, we see child support. The client indicates he does currently receive child support in the amount of $360. We can click this pencil and review this information. Here, it says 300. Well, you want to make sure that the data you're entering, again, is complete, it's current, it's consistent, and correct. So we're not going to just change this amount. No, we need to end this data. Save here. Answer accordingly. Save here. And then the client reports that they are also receiving unemployment insurance. We're going to click this pencil, review the amount. You guys can disregard this. It was previous training. Review this amount in the amount of $1,000. And the client says, yes, I received $250 a week in unemployment. From here, we're going to save. And now we know that our information is complete, current, consistent, and correct. We're going to make sure that it all matches up here. we added $60 to it, so we want to make sure we're reporting that. We can, again, it's just like any of the other data that's in here. We cannot assume that the data that is existing here is current. I hate saying complete, current, consistent, and correct over and over again, but it does kind of stick in your head after you hear it 3,000 times. So something like this, we see this a lot where, you know, we've changed that the client doesn't receive any income, but we can see here that there's information here and information in here. When you guys go to review the client's history, you can click on the magnifying glass. Anything with a monthly amount, you want to look for anything that's open. So there's this one and this one. So those are only the ones that we just added today. So we are good. From here, we're just going to continue to ask and answer. All additional information questions must be asked. They must be answered. I take hop back on my soapbox a bit for our domestic violence victim and survivor questions. 2 years ago, 2019, we put in a application to receive domestic violence bonus funding for clients that are fleeing domestic violence or are survivors of domestic violence. The only place in our CSIS system for us to be able to report on those clients that are fleeing or are survivors is this data. We did not receive that funding, whether it was because we didn't identify the need based on the data or not, I'm not sure, but I please implore all of you to ask and answer accordingly with our clients. Please tell their story. Are you pregnant, registered sex offender, substance abuse user, and have a housing voucher? Please answer all of these questions. From here, our contact information. This is such a huge part of the client's story. I understand that this information here says last permanent address. I would like everybody to just disregard the last permanent address and use this as your client's contact information. Please add any contact information on the client that they have. So here we have that Brandon is staying at 1234 Happy Place, but we know that he is literally homeless. So we want to make sure that we end this location. He is no longer in this residence. If there are old residents on here, let's see. Oh, I don't want to do all that. Let's see, anything that has an open end date. So it's just that location. If you guys see multiple dates that are not current and correct, please end them. It will save a lot of people and a lot of time in the long run. When we have clients with long histories of homelessness in our system and they've updated their information a bunch of times, their phone numbers changed 15 million times, their addresses are all over the place. When we see open data in here, it looks like that's where the client's living because there's no end date. Just like here, if I had left this open, it would look like to the system that this client is still living at that location. So we always want to make sure that if this information is not current or correct, that we are ending it. End it for the day before and add another. If the client is staying in an encampment or Central and 9th, Sarasota, but we want to get that client's, if possible, cell phone number. please keep that in mind. It will help us. We are able to connect with clients after the fact, after they've received an intake. If there's information in there for us to send a referral, the referring agency can call that client to determine their interest in engaging with the project. We have a couple people on staff that are able to connect with clients and determine whether they are still in need of housing intervention services. So we can either move them from one side of the list to another, whether they're active and homeless in the system, or maybe they've self-resolved. So please do your best to look at this contact information as if this client were to get a referral to a housing intervention service, a referral to a rapid rehousing provider, a permanent supportive housing provider, how would that provider be able to connect with that client? This is what we're using this information for in this assessment. So please just look at this as if it says client's contact information. We're going to save. Now we can see these old ones. They don't exist anymore. He's not living here. He's over here. He's staying at this encampment. I feel like I spelled encampment wrong. And it's active. So we know this phone number is still good. This location ended, but the phone number is still good. Same thing with emergency contacts. We can use emergency contacts to relay a message to the client for the client to be able to reconnect with us as an agency. When we were managing, I was managing the by name list for the veterans. I would call the veterans emergency contact and say, hey, we're looking for Joe Smith, you're listed as his emergency contact. Oh, Joe's right here next to me. He's fine. We're in Minnesota. I took him in. Well, now we don't have to worry about Joe anymore. Joe has self-resolved. So just little things like that really help the system operate more efficiently by providing updated information on client contacts. From here, we get into our VI SPDAT. The VI SPDAT is a vulnerability index prioritization and assessment tool. So what that means is that there is a list of questions that we ask the client, and based on the responses, there will be a score added to the client's CSIS record. This score will help us determine how vulnerable the client is and what housing service will be most appropriate for that client. So when we get to the VI SPDAT, there are 3 VI SPDATs. We have a VI SPDAT for individuals 25 years or older. We have a VI SPDAT for an adult child family. So this would be a family household. And then we have a VI SPDAT for our unaccompanied homeless youth. Obviously, Brandon doesn't identify all of these different projects. Typically, you may see 1 or 2 for a client who has a long history of homelessness in our continuum, but you always want to make sure that you're updating this information. If you're adding a client into a coordinated entry intake, you're adding a VI SPDAT. So from here, we're going to add, because Brandon's a single individual. Well, he's in a family, but all of the members of the household are 25 years or older. So we're going to add. And I recommend anybody that is going to do these, to do the VI SPDATs and regularly conduct coordinated entry intakes, print this questionnaire out. After you calculate it and answer all the questions, you can print it out at the bottom and familiarize yourself with the questions. Some of these questions are very sensitive in content, and they can, if you're not used to asking the questions, it might feel a little intrusive, I guess. But it's all about triaging the client. For those of you who are experienced in adding VI SPDATs and conducting this assessment, maybe Aaron or Nick or Brian, of course, do you guys have any recommendations before we get into reading the 40 questions that are on this assessment?
Usually when you update their profile, if you take your time and do that, you kind of win. So start to get to know a little bit, and then when you get to these questions, they're more apt to kind of tell you the truth.
Mm-hmm.
And sometimes you know the answer before you ask the question. So if you know what the answer is and they answer it wrong, sometimes you can ask the question maybe a little bit differently so they understand what the question's trying to get at.
Mm-hmm. And Brian Scott, I just saw your question. So Brian Scott earlier had asked if the client identifies that they suffer from alcohol and drug abuse, do we mark yes on all 3 categories or just the type that says both? We want just the type that says both. If we're adding disability, it's extra work. It's a duplication of effort, really, when it comes down to it. So you would just do I'm going to respond to your chat, both drug and alcohol. And then, of course, for clients who only identify if one or the other, then you would respond one or the other. And then, so just trying to get a little bit more background. Ursula, Carmen, do you guys, I know that you've done a couple of these VI SPDATs. Do you have any, or I actually don't know that you have. I feel like maybe Carmen has. Aaron?
I was going to say, I did have a question.
Yeah.
Because on the benchmark, it's got 3 questions regarding their homelessness, which 2 and 3 answers 2 of them. But where it says, have they been street homeless for more than 12 months in the last 3 years? There's nowhere that really specifies that. Because what if they were homeless 5 times, but it was only for like a week or 2 each time?
I would add that to your TA list, honestly.
Okay.
Because there isn't a place, and that's
I was going to say, making sure I didn't miss anything on the VI.
That's not a question, and it's if it's street homelessness, I'd have to follow up with me after this so we can. But in your experience in doing the VI SPDATs with clients entering it, do you have any recommendations? Just kind of read the questions or
I mean, make sure, yeah. These are very important questions, so make sure that you get the most accurate answers, really.
Mm-hmm. I'm trying to get us all like together and using our previous experience with those that are new. So because I've never given a VI SPDAT. I'm on this side of things. I'm on the trainer side of things, and I love when we have people that are learn from my experience kind of thing. You can just rattle off all these questions. I think one of the biggest recommendations that I've heard is because clients are so used to doors being slammed in their face for being honest with their homeless experience, ensuring that how the client reports will only assist them in getting connected to the right services. So reminding the client that this is not punitive, and the way for us to appropriately connect you to the right services, we need your story. We need to hear what you are actually experiencing. Tell us what how many times, for instance, you've been in the emergency room. If you, like, for Holly, Brian and Brian, when we were on the call, we were saying like, hey, isn't how Friday, this information, shouldn't it be correct? Well, not necessarily, because we may have clients who have a long history of mental health disorders and maybe different experiences of being Baker acted or sent to detox centers, or involuntarily or voluntarily, whatever the case may be. But when clients are met with these questions, they're so used to minimizing their experiences because of the outcomes of them actually telling the real story. When I tell you, yes, I've been Baker acted 4 times in the last 6 months, and yes, that I've gone to a detox center twice, people say, oh, well, I can't help you. So clients, I mean, just like all of us, you tell the story that you want the person to hear, because you're trying your hardest to get into the system so you could stop being homeless. I think having that honest conversation up front, like, hey, this is a triage tool. Tell us your story. Tell me your story so I can enter it correctly and get you connected to the services that you really need. If you don't feel comfortable answering some of these questions honestly, I understand that, but all of these questions are just going to help us connect you more appropriately to the right services. There are too many times where we have clients who come into the system that identify as having maybe a lower level of care, but then after we connect with them and we refer them to another agency who could provide that lower level of care service, when we start talking to the client, the truth comes out, and then we're left with not being able to help the client in that project, and the client's again, left with nothing. So I think being upfront and forefront about these questions and saying, this should be honest and based on your experiences while homeless. You will not be denied or, anything based on what you tell me here today. It's just a triage tool for us to connect you appropriately. If anybody has anything they want to throw in the chat, welcome to it. We've got, Livney and Brian Scott. You guys are very new to our system, and I really want, people who have that experience to be able to provide you that historical reference. If not, then we'll just continue. So I can rattle off these questions. This does take about 30 minutes to go through, as well as Erin, go ahead.
Sorry. I will say too, what you've mentioned before, like making it more of a conversation is so crucial for the VI SPDATs as well, because of how personal the questions are. If you kind of find your own script after doing it so many times, but making it a conversation instead of asking them questions, you get much more reliable answers, like honest answers.
Great, thank you. That's an excellent recommendation. Yeah, because I mean, when we're going through and really all of this access point information, thank you for that reminder, all of this data, all of this access point information, I mean, if we've had a diversion conversation with the client beforehand, where we were already asking, where did you stay last night? How long have you been there? Are you safe staying there? And what's your income? What is this? What is that? Having this conversation, including questions in your diversion conversation will help you. It will help drive your assessment process. It will help it feel more relaxed and less like a intake worker or a poll worker. You become more of a person that is trying to triage the client, and we're trying to have a conversation so that we get you connected. Great recommendation, Erin. Thank you so much for that. So we're asking, where do you sleep most frequently? Erin, this might be maybe if we're looking at your benchmarks tool, if it's outdoors, I don't. That might help you. But we're going to ask the client. So you've been at the emergency shelter a couple nights. Where is it most likely that you sleep? It's like, yeah, I'm actually in encampment mainly. And Lucy and Avery, you guys would, most of your clients, I believe, because you're in that Centerstone outreach project, you're working with those clients that don't have regular shelter stays. They're clients that very rarely access the system, maybe. So outdoors. And then how long has it been since you were last in stable housing? And in the last 3 years, how many times have you been homeless? So Brandon had identified earlier to us, I think he said 2. We're going to say 2 now. And then when we're looking at number 4, these 4A through 4F are in the last 6 months. How many times have you received health care in an emergency room? Been taken to an ambulance, taken an ambulance to the hospital, been hospitalized as an inpatient. We'll say that Brandon was sent to, maybe he was Baker acted last month or something like that. Did he use a crisis service, including a sexual assault crisis, a mental health crisis, or family intervention, intimate violence, distress centers, and suicide prevention? So we'll say that he used that service when he was Baker acted, just that one time. How many times were you talked to the police? Let me zoom in just a bit because it is a little small. How many times have you talked to the police because you witnessed a crime, were the victim of a crime, or the alleged perpetrator of a crime, or you were told that you just simply must move it along? I think in definitely city of Sarasota County, we have a lot of homeless outreach team members, and maybe they're not the police, or maybe the police have asked clients to move that along. They don't have to have gone to jail, but how many times have you been asked to move it along because of your homelessness? So we'll say 2 for that. Stayed 1 night or more in a holding cell, jail, or prison, whether that was a short-term stay like a drunk tank, a longer stay for a more serious offense, or anything in between. Just ask the client. This is something that we find out later that, sometimes clients aren't always the most honest about, where we're like, oh, do you have any misdemeanors or anything like that? And then no, none. And then when we look at their record, it's like, whoa. So just having that conversation, said, okay, well, that's 1, 2, 3, 5, whatever the case may be. Have you been attacked or beaten up since you've become homeless? It's a yes or no. Threatened to harm yourself or anyone else. And yes, Brandon was actually, that was why he was Baker acted. He had threatened to harm himself, and his wife was concerned. So she called and they sent out a CSU for him. Do you have any legal stuff going on right now that may result in being locked up, having to pay fines, or that make it more difficult to find a place to live? Clients with evictions on their records. This would make it more difficult for a client to find a place to live. That is the reality of it. We're going to say yes here. Does anybody force you to or trick you to do things you do not want to do? We're going to say yes or no. There was this one client or one case manager who had said, hey, it can even be something like, there's this one client that, always hits me up for cigarettes anytime I have him. He says he's going to pay me back, but he never does. Or the clients that they know that you get a monthly disability income, and they'll come hanging around that first of the month, like Brian was talking about, in order to stay at the hotel with you. And then as soon as, the hotel stays over, they're out the door. They don't ever even know you again, or until the next month, stuff like that. Do you ever do things that may be considered risky, like exchange sex for money, run drugs for someone, have unprotected sex with someone you don't know, share a needle, or anything like that? This is where, again, Erin and I were saying how these questions are, they're pretty sensitive, and we're talking about things that are we're trying to get a triage situation going on so we can determine how vulnerable the client is. Is there any person, past landlord, business, bookie, dealer, or government group like the IRS that thinks you owe them money? That response is yes. Brandon was evicted. His landlord still wants that money, and he's filed suit against him. Whatever the case may be. Do you get any money from the government, a pension, inheritance, working under the table, or a regular job? Well, we will have already known this answer because the client identified earlier that they are receiving unemployment and child support. So oftentimes by the time we get to this response, we will know yes or no. But then say earlier the client had said no. And then now the client is saying, oh yeah, I have, child support that comes to me. Go for it, Brian.
On your thing, risky behavior with COVID, sharing bottles of booze on the street, is that considered risky? I mean, they hang out all the time, close company, so.
I would 100% say yes.
Street, just being on the street right now without a mask is risky.
100%. I think that is, and thank you for that example. And I'm going to use that going forward and recommend that Ryan also use that. That is a very, very good example of risky behavior. I mean, like you said, just being out on the streets without a mask at this point is very risky behavior. Thank you so much for that recommendation. 100%. I think that's risky. I'm not going to get political, but I think just being in the streets and not practicing regular hand sanitation and basic hygiene, you're putting yourself at risk of other infections, not COVID aside.
Yeah. You asked the question, and it sounds like, well, it's really sharing needles, unprotected sex. I mean, that's extremely risky behavior. But again, just common day-to-day stuff out there, because I see them passing liquor bottles around quite often on the streets.
Absolutely, I 100%. I'm taking that. Thank you for that example. It's mine now. No, I'm just kidding. But this is what I love doing these trainings, especially with users like yourself who have this historical context and have this real life, boots on the ground to help other users kind of ease that question in. And maybe what, like you just said, risky sex, nobody's going to say, oh yeah, I, have sex all the time without a condom, Russian roulette, whatever. That's a little bit more, people are less forthcoming with that than just in light of the current pandemic that we are still in. We are still in a pandemic, regardless of mandates, mask mandates or not. There is still a virus floating around, and if you are sharing liquor bottles and passing and in close quarters with other clients, you are definitely, in my opinion, putting yourself at risk. I conduct these trainings virtually because I can't put myself at risk. Thank you, Brian, so much for that. Okay, so we went back, so we were talking about the income. If the client states yes here, and maybe they hadn't before in our income HUD verification sub-assessment, something we want to circle back to and say, oh, you receive income? What kind of income? I want to make sure that we capture that in our income area. I'm sure if you said assessment, they'd be like, what? So do you have planned activities other than just surviving that make you feel happy and fulfilled? Who are we to judge what a client's planned activity is? If their planned activity, Brian, is to go to the Publix liquor store, grab that pint and share it with their friends down by the Van Wezel, then that's something that they planned and they do every day to survive. That's something that they do other than surviving that makes them feel happy and fulfilled. That is a yes or no. Are you currently able to take care? So this question always gets a little, people read into it differently. But the question is, are you able to take care of basic needs like bathing, changing clothes, using the restroom, getting food and clean water, and other things like that? We are asking the client, are you physically capable? So not if the client is, do you have a restroom that you use and you can take a shower and change your clothes? Do you go somewhere like Open Door over at Turning Points, or even the Salvation Army Sarasota? Whatever the case may be, we want to make sure that we are communicating that the client is physically capable, so that the client doesn't need any kind of assistance that would require that, like ALF, assisted living facility care, where they need someone to help them take care of those needs. That is what this question is asking. Because a lot of clients, well, yeah, I'm able to, but I don't have a place to do that at. In reality, they do at Turning Points and the Salvation Army Sarasota, they offer those types of services. So keep in mind that we are asking if the client is physically able to. Is your current homelessness in any way caused by a relationship that broke down, an unhealthy or abusive relationship, or because family or friends caused you to become evicted? So we're just simply going to say yes or no. It just depends on the client's story. Tell that story. How did maybe we already identified with the client and we're just affirming this or confirming this, that the client was evicted from their previous place because they lost their job. Their family's intact. No relationships broke down. They just, COVID hit, lost their job, couldn't get ends to meet, and now, much like a lot of other clients, are literally homeless on the street. It really just depends on the client's story. When we're talking about wellness, we're asking, this is going back to those disability conversations. And when we were asking what the client's disabilities are, have you ever had to leave an apartment shelter program or other place you were staying because of your physical health? Maybe the client was in a place and their physical health was deteriorating and that led them to becoming evicted. There are places like clients that may enter the shelter and maybe their physical health is too much for the client to be able to sustain in that shelter environment. I've heard many instances in which a client has physically deteriorated by being, and it's nothing against the shelter, but by being in that shelter environment. And then once they've moved out of that shelter environment, they have improved. They're able to get that higher level of care than the shelter. The shelter is not a medical facility. We are not, we have very, very dedicated shelter staff, but they are not trained medical professionals who can provide that care for clients. So this was an example that another user had brought up of clients deteriorating in the shelter because they're not able to provide that care. And then once they get into a more appropriate setting, they can rebuild their functions and their ability to live independently. Do you have any chronic health issues? Brandon had identified earlier that yes, in fact, he does. If there was a space available in a program that specifically assists people that live with HIV or AIDS, would that be of interest to you? So if we have clients that have responded yes to this question, but not to the do you have HIV or AIDS disability question, we want to remind the client that this program would be specific to those with an HIV or AIDS diagnosis. And not just, sure, are they going to pay my rent? Because I'll stay there, This would be a client that has identified as having an HIV or AIDS diagnosis in their disability as well as here. answering yes here and no on your HIV or AIDS disability subassessment would be inconsistent information. So it's either a yes in both fields or a no in both fields. Do you have any physical disabilities that would make it difficult for you to, or that would limit the type of housing you could access, or would make it hard to live independently because you need help? Same question. We just want to make sure that we are reminding ourselves that this is more speaking to the independent part of that physical condition. Does that physical condition limit their ability to live independently? We're going to say no for Brandon. When you are sick or not feeling well, do you avoid getting help? Who doesn't? I don't have health insurance to get help. No, I mean, that's the reality of it at times. But we do want to make sure that we are asking the question that if you were really sick, would you go to the, Brian, you just, bring it on.
Yeah, I mean, when you get to the independent question, sometimes people can't get upstairs, and that's it. They can live independently, but because they can't physically get up and downstairs, or they're in a wheelchair, I mean, not that they can't live independently, but the place that you're trying to house them might not be able to. Apartments that have stairs and things like that. Would you answer yes if you have physical limitations, but not that it would prevent you from living independently, but it would limit the place that you could live?
So that kind of information, thank you for that question. That kind of information would be more appropriate to be addressed in a note. You can add a client note. But when we are focusing on these questions about physical conditions, yes, we want to say that the client does have a physical health condition. Both of Brandon's legs are amputated and he is in a wheelchair. Let me just go through this and save this real quick. Son of a gun. Okay. Brandon is in a wheelchair, and that will limit the type of housing that he can access. But something like that would be better approached during that rapid rehousing when we're trying to identify those housing resources. Right now, we're saying that, go ahead.
Independently, that's it.
Exactly. We're saying that Brandon can independently live. He's physically disabled, but he can live independently. Whereas if a client obviously could not live independently and was physically disabled, we'd be working in a different realm of housing options. Great question. Thank you so much. So Brandon does not avoid getting sick. Brandon is not pregnant. Has your drinking or drug use led you to being kicked out of an apartment or program where you were staying in the past? That is a yes or no. I know that this is something, same issue. Clients might say no here, but then we have a history of being asked to leave the shelter because they were bringing alcohol, and having that historical reference, maybe by reviewing case notes or not case notes, but client notes in CSIS, or if we can review the information that's in the system. We don't want to have a gotcha moment with the client, but we do want to kind of say, oh, well, when you were staying back in City Hot, you know, you were exited from the project for drinking and bringing alcohol, or I saw that there was an incident where you brought alcohol on the premise and experienced a ban, or even if you just know the client and have that experience with the client where you're like, well, you were asked to leave last week because you brought alcohol on the property. It's nothing, reminding the client that we are not trying to, this will not bar you from entry into any project that you could potentially receive a referral to. But we're just trying to get the right story here. We're trying to triage you appropriately. Yes or no? I'm sure, Aaron, in your experience at GPD, most of the clients entering into a treatment program or a GPD bed, it's with that intention of getting treatment for an addiction. So when we're asking, will drinking or drug use make it difficult for you to stay housed or afford your housing? This is something that is common, that yes, if I am spending all of my money on my crack cocaine addiction, it is going to be very difficult for me to maintain my housing. That's how I ended up homeless, or whatever the case may be. At a time there, go ahead, Aaron. Yes.
Sorry. I was going to say, and to note on that, that's where that conversation piece is actually very helpful, because oftentimes you'll see that if you ask a question like, will drinking or drug use make it difficult? Be like, oh no, I've never been evicted or had any issues like that. But when you put it in perspective in that conversation, like, has it ever been hard for you to maintain housing because of the financial part that comes with drug use? Mm-hmm. Then they understand a little better, and the answer totally changes.
And that's where we, and not to point out any, flaws within the system, but that's where we're seeing these, not even cultural, but like just approaching the question differently. We want a standardized assessment approach, right? But some people are going to ask more questions like, well, will using crack cocaine regularly, I know that's something you have identified as doing, that's pretty financially straining. Will you be able to afford your rent and your addiction? What is the situation? Go ahead, Brian.
Can we make a judgment call? If we know that drinking, because they've been in and out of these different programs and they've been in and out of hot, and that it is drinking, and they say no, but we all know the answer is yes. Do we put yes, or do we have to put no based on their answer, when in fact we know the answer is yes?
So this has always been a question that I cannot, in my own, if a client is attesting to you one way or the other, it is my personal belief that we should be reporting answers in our system based on the story that the client is telling us. There are other members, there are other people who feel like this is an opportunity to use your judgment and respond based on your experiences and your observations with the client. So I cannot, for my own self, say, yes, report on your based on your experiences.
You don't want a yes to be a bad answer, because we've got two people right now that are in housing, and their problem is they can't make it. They just drink too much all the time. But they're the people that we should be helping, and this is housing first. Maybe if we get them housed, we'd have them in a position where you could work on the drinking.
Yes, 100%. That's the idea. But again, to answer your question, I recommend only reporting what the client states is reportable. I'll leave that one up to you, because you're the one making the judgment call, honestly. I can see why it would be one of those tricky situations where it's like, I know this person has an addiction issue, but I'm sure any of us that have experience in addiction, whether working with addiction or living with addiction, regardless of how you feel about their addiction, if they're not ready to admit to the problem, regardless of whether they're housed or not, they're saying yes or no here. I don't know how much of an impact on the client's story it will be if that client is not ready, willing, and able to come to terms with that addiction. So I'm going to leave that kind of up to your discretion. but just keep in mind that we're telling the client's story, and maybe that part of the story is better told in a client note or after we have triaged the client and connected them accordingly. Because whether the client answers yes or no to this question, self-attest or you attest yes or no to this question, it will not significantly impact the housing options for that client, if that helps at all. It could help approach the client differently once attached to a rapid rehousing provider, but go ahead.
No, you just don't want to penalize him, because if it says will he drink and he can't stay housed, then all of a sudden, oh, well, we don't want to put him on the list. You don't want that to happen. So.
Well, we will definitely, Southwest Partnership will never not put somebody on the list of their housing. But and we have to keep in mind, maybe it is about when we're talking specifically observation based versus self attestation. If this client, we have to keep in mind that forward thinking, if this client was housed, would their addiction be as bad or even continue? And none of this in this call are capable of making that prediction. If we are, then we're in the field, because we should be psychics or something, right? So we should always, just in my opinion, and the only way that I will ever train is to base it off of the client's self-attestation. And if it's something that you feel like is warranted to be discussed at a different time, that after the client is connected to housing intervention service, or even just on a one-to-one with the client and something you would like to offer as a service provider, I think that would be a more appropriate time to have that conversation. Because and maybe just reminding the client, your honesty, you will not be penalized for your honesty. We will better connect you to a service. If you have that feeling and that drive to respond based on your observation, having that conversation that if you tell me yes here, it's not going to affect your placement on the community by name list, or it's not going to affect whether you're connected to services or not. Honesty is how we're going to connect you with the most appropriate.
You're muted, Lauren. I was wondering, I was like, why did it just go silent?
Did it mute? Okay, so did it mute me asking you if you had any questions? When did it mute me?
Sure did.
Okay, great. So my question was, do you have any recommendations for Brian's concerns based on your experience working in that treatment-centered environment?
As far as
observation versus self-attestation for these questions related to drinking.
I'm like, I mean, personally, I typically would, if I've been doing an assessment with this person for 2-3 hours and I know they're not giving me the exact correct answer, I would fill it in with what is obviously true, even if they're not saying that.
Okay. That's
saying things I'm like, I don't know if that's like the right thing to do.
It's not right or wrong. This is the one area that, and historically in the continuum, these are the two questions on this BI SPDAT that have been debatable of self-attestation versus observation. So I like to thank you for being honest. I appreciate that. You know, it's
because too, when it comes to like, if they're not being honest, it could be because they're afraid it could disqualify them. but like after this conversation, 100% the right answer is not what they're reporting. By putting the right answer in there and the way the coordinated entry works, it actually is going to help coordinated entry work the way it's supposed to.
Absolutely.
They'll be bumped up in priority instead of having a lower score.
It will definitely assist with connecting them. I mean, a lot of times you think like clients, and this is the thing, is clients are like so used to minimizing their experiences, but in reality, the higher need you have, the more quickly and the more accurately we can connect you to the services that can provide those. I do want to move on. Okay, we only have a couple more questions. Thank you both for your dialogue. I really appreciate that, and I hope everybody that's newer on the call can use this dialogue to drive your conversations going forward. Okay, so 23A through C. Have you ever had trouble maintaining your housing, or been kicked out of an apartment shelter program or other place you were staying because of a mental health issue or concern, a past head injury, a learning disability, developmental disability, or other? Again, this is one of those things that if you know this client and the client was discharged because they were having a mental health crisis or an experience caused by their schizophrenia or a mental health, an experience caused by their mental health disorder, that is a self-attestation observation kind of situation where it would be based on your, how you feel that you should interpret that response. Do you have any mental health or brain issues that would make it hard for you to live? There's that key word, independently, because you need help. Are there any medications the doctor said you should be taking for that whatever reason you are not? Brandon is not currently on his bipolar disorder medication. So that's something that we, if we're able to, can really connect and help the client. Maybe we have a connection at Coastal where we can set that client up with a referral based off of a warm handoff, something like that, so the client can get back on their medication and hopefully stabilize. Are there any medications like painkillers that you do not take the way the doctor prescribes or where you sell the medication? From here, yes or no? Has your current period of homelessness been caused by an experience of emotional, physical, psychological, sexual, or other type of abuse, or by any other trauma you have experienced? This is a yes or no. I think when we're talking about traumatic events and when we're talking about clients' experiences, I mean, honestly, before COVID, we could say that most of the clients that are literally homeless on our streets, they had some type of trauma. When people ask me, in my personal life, oh, you work with homeless people. Well, what comes first, the substance abuse or the addiction or homelessness? And my response is trauma comes first. Our clients that are literally homeless on the streets, even each one of us has experienced some type of trauma in our lives. It's just that our experience didn't result in homelessness. We maybe had the support networks, coping mechanisms, or tools that kept us in a stable situation. But at the same time, our clients, they have experienced homelessness, and without those adequate resources, support networks, and tools, ended up homeless. Can be the same with the COVID-19 pandemic. Clients that lost their jobs abruptly due to COVID-19, I mean, there are top 5 traumatic events, and losing your job is one of those events. You can correlate that loss of income, loss of job to a traumatic event. This is, again, self-attestation and how the client reports. Maybe Brandon doesn't think his loss of income was very traumatic, but it did result in his homelessness. So having that conversation. From here, What this does down here is we calculate it, and based on the client's total score, this is how we're going to appropriately assess the client and connect them to the right intervention. Looking at all of this information, we know that clients that typically score in the 4 to 8, 9 realm are those rapid rehousing clients, and clients that score over 9 and above, we're really looking at those permanent supportive housing situations where clients may need longer, more intensive case management than somebody that enters a rapid rehousing program. Clients entering rapid rehousing programs ideally will stabilize on their own. Making clients aware of rapid rehousing, that's a different training, but having that conversation up front in rapid rehousing that the goal and the intention of this program is to assist you into housing and connect you with resources, but you are going to stabilize on your own. If that's not something you're ready to do, then maybe this isn't the right program for you. Either way, Brandon is a 9 right now, so we are going to save. This information will help us over on the coordinated entry side better assess the client's needs and look to see what's available for this client based off the information here, the information collected in their income, disability, their total length of time homeless. It really just varies. If I were looking at this story, you know, I think permanent supportive housing might be a little bit extreme for Brandon because he was working regularly before COVID hit and he was living independently. So that's stuff that we talk about in case conferencing. From here, we add our coordinated entry assessment. This is very basic. We're going to add, click here. Assessment location is your location. The type is in person. The level is housing needs assessment. And your prioritization status is placed on prioritization list. This is without fail a very basic, there's not much room for interpretation on this one. This is what it will look like based on maybe your TSA Sarasota, and that's the only thing that changes. Based on where you're conducting it, what location, and then if you are doing it virtually or in person. From here, we save. Scroll to the bottom, same thing. Oh, that was earlier. I gotta figure out why that thing mutes me. It's very, very frustrating. From here, let me zoom out a bit. Straight down the list, event, referral to housing navigation project or services. Simply scroll and save. If the client was going to be referred to emergency shelter bed, you could add that referral as well. But after this, adding this information, you know that your data is complete, current, consistent, and correct. We are going to save and exit. Following our 1-by-1 intake instructions, we're going to go down. Here's your coordinated entry assessment, coordinated entry event, save and exit. Now we have to create a referral in the system. So we are going to, and the step-by-steps are on this sheet until you guys get comfortable. Service transactions, add referral, just the head of household, I don't know, it should have listed, that's weird. Your service code quick list, if you are in the access point EDA, will be housing related coordinated entry. I'm not sure why it's not showing up for on Nick's EDA. Oh, wait, there it is. I'm sorry, guys. See, we all make mistakes. And we need to remove these other ones because there should only be 1x1 Suncoast partnership on here. So we add 1x1. Scroll, scroll, scroll. Your referral ranking can be high, medium, low. Erin brought it to my attention that some people don't know how to rank these, and maybe we should start ranking them by BI SPDAT score. I think that's a fabulous idea. So that's how I'm going to train. If the client scores 8 or above, let's say high. If they're below an 8, 8 to 4, let's do medium, and below 4, 1 to 3, let's do low. We're going to do high. We're going to notify the service provider by email. That's going to tell Suncoast Partnership, hey, you have a referral. And then we're going to save all. Send on that referral. And now we have just about finished. From here, we're going to jump into our PowerPoint real quick. We went through all this stuff. You guys will have this for reference. Historically, we used to exit clients from 1x1. You will not be doing that. You guys, after you complete your referral, if you want to add a client note to the client profile, this will help the COC, you guys as service providers, and then potentially our 1x1 project manager when they come on board. Give Brian, if there were little things that you in the client's story that you thought would be helpful for fellow COC providers to know about. You know, client is in wheelchair, but this does not affect or effect, I can never remember, client's ability to live independently. Something very general. Client is often at bus stop on Central and 9th Street. Client goes to res house or mail. Any kind of very generic information that you think will be helpful in assessing this client's needs, put it on the client profile note. Do not put any personal health information, any PHI information. General rule of thumb for client notes on the client profile, if you wouldn't want the information shared about yourself in this note, then don't share it for the client, because the entire COC can see this information. So please be very mindful of the information that's added here. We don't want to, if you want to report the client's history of being Baker acted, this is not the location to do that. You can add a case plan to report that note if you wanted to, so it's protected, and only very few people can see that. Just be very mindful of the information that you add here, because everybody can see it. So we're just going to add a little note like that, just to kind of guide the person who may be working with this client next and give them a little assistance. From here, we are done. What else can we do for the client? Does the client need, they had talked about needing medication and they don't have any health insurance. Do we have an in at Coastal, or do you know somewhere where we can refer the client to getting a prescription filled, or who was their previous doctor? I know that you guys aren't paid to case manage every single client that comes into your door, but really when we're at the end of this coordinated entry intake, we're really asking, what else can we do? Can we provide the client a shelter, a shower, or, you know, I know there are just a tremendous amount of services offered at Turning Points that you guys could potentially offer the client. whatever the case may be. For any veteran clients, Erin, do you have any recommendations for veteran clients that come in through the coordinated entry system that may not have been connected with a veteran service provider, or maybe some guidance for those intakes if clients identify as a veteran?
I mean, making sure that the U.S. military veteran is actually checked as yes.
Right
We've run
here.
into that issue. And also, all the organizations working directly with clients have access to Squares, which is a very valuable resource. So checking down at the bottom where people upload files to see if they have a Squares report already uploaded, or running that report and putting it in there is very helpful, because it shows their eligibility for GPDs, SSVF programs, all that good stuff.
Yeah, I don't think so. Anybody on this call, I don't think would have, because I don't think the Salvation Army Sarasota has, I think.
If they have a veteran, though, a lot of them have the Squares in the bottom, and that can be helpful to like who they need to reach out for.
Okay. And yeah, Erin, so just being mindful that if you have veterans, if they've identified as a veteran, you know.
Yes!
What, Nick, what was that? You unmuted or something. What are you watching? You tell on yourself worse than anybody else I know. I tell you what. Veteran status is listed here. If the client identifies as having a veteran or being a veteran, this is where we want to make sure that we are identifying that, and then ensuring that the client knows about the services provided in the community, that, you know, JFCS and St. Vincent de Paul, and also Turning Point still has veteran programs that they work with, so that the client knows that they will be connected to somebody. Our veterans have a not completely different, but a different operating system than the rest of our individuals and civilians. So, do we have any more questions, or any questions at all?
Yeah, the most important question. As soon as you finish this, their question usually is, okay, now we've got you in the housing profile. Somebody will be contacting you.
No, we should never be having that conversation.
Well, they always ask. It's like, okay, well, you could get called in a month, you get called in 6 months, you could get called, you know. We never have a good answer to say, okay, thank you for doing this. Now that you're in the system, now go back out on the street and.
Well, that's the reality.
Well, that is the reality, but what's
the reality.
Good answer to tell them on, you might get contacted this year?
Yeah, honestly, that should never be communicated. And I don't mean to be firm with anyone, but at the same time, we should be having this conversation about, before we even enter data as an access point, the conversation and the communication with our clients is, this is a community by name list. The reality is there are 315 people already on this community by name list, and using the analogy of a deli. And
that's the exact answer we give. And sometimes it's kind of harsh because they think they're going to get immediately contacted and they're going to get housing. And that's the answer we always give them is, you're in the list, it'll come up. And, you know, depending on where the score and of all the other people ahead of you, I can't give you an answer on that.
And that is it's unfortunate that I'm sure, Brian, you too, we all wish we got in this industry to end homelessness. If I could hand out vouchers and attach affordable housing to each one of those vouchers and call people tomorrow, we would do it. But reality, I mean, that's not the reality. And giving clients, and I'm not saying you are at all, I'm saying in general, that false hope.
Exactly.
it's
So,
Right.
so basically, like when we're done with this and they say, well, what now? We just say, now we wait, basically.
no, waiting is not an activity. So hold on, Nick. So waiting is when I was at a conference in Los Angeles person. She's the director of the COC over there. Her motto is waiting is not an activity. What can we do? What can you do to resolve your homelessness? Because waiting is not an activity. And the likelihood of you receiving a call within the reality is, friends, we have 315 people currently on this by name list. And of those 315 people, we have identified 30 who have been waiting since 2018 and are still active in our COC. That is 3 years of waiting and who have remained homeless since 2018. Those are our priority clients. When we are talking with the clients, getting them identified and added to this list, depending on their situation, this is not the last stop for them. It is, what else can we do? How can you resolve your homelessness? How can we work together? Because this is the reality that you're in line, you are in the essentially the back of the line, depending on the client's story, of course. The back of the line. Are you going to wait? We've already identified 30 people, our next 30 people that are going to be offered housing intervention services. What else can we do so that the client isn't waiting off false hope? I had Aaron and then Nick.
Oh, I was just going to say, good news is for veterans, they will be contacted.
Veterans do work slightly different. Yes.
So if you have any veterans that ask you that question after you complete the access point, I will put a referral out within 24 to 48 hours to a veteran pre-enrollment. So within 1 week, they should hear from somebody to get them connected with services.
But those are veterans.
Yeah, only veterans.
Of the probably, 50 access points that we get a month, 3 or 4 of those are veterans. So those are 46 other people what else are we going to do? Nick?
So, hey, everybody, I'm Nick. I'm sorry. I was doing a lot of stuff at the same time. What I usually say after I complete an access point or before I do an access point is letting people know that once we do the access point, you have now been identified as being homeless. That's what this is for. Not saying that you will get any government funds or anything like that, but we have now identified that you are homeless in our community. But you still have to try to move forward on your own. If you get contacted or not, we now identify that you're in a situation and that we will do our due diligence to try to help, but at the same time, you need to try to move forward to help yourself. That's what usually I say.
That's good.
So they don't get confused and waiting on, oh, I'm just going to sit here and wait. Like, no, that's not what this is for. This is, if you don't do it, then no one will ever know you're homeless. But if you do it, now we know, and there's a chance that you may or may not. But at this time, now we know you're homeless. But you still need to work on getting yourself out of your situation.
Thank you so much, Nick.
All right.
Yeah, I mean, we historically had, I just think that this, thank you. That is excellent language. This list is to identify our literally homeless clients and triage them to potentially connect them to appropriate housing services. And using that language, identify and triage. And when we're talking about realistic conversations, the reality is you've only been homeless, but your homeless experience is quite shorter than a lot of other clients in our system, or that your homeless experience, I don't know, not judging it. I encourage anybody else to, I don't have the words for it, honestly, because I'm a very direct person and I don't know that. I think Nick can
Well,
attest to that. Go ahead, Brian Scott.
It's a slippery slope if you think about it. I mean, if we know that the homeless population talk to each other, so if one comes in and does this assessment, and at the end we state what you just said, that you've only been homeless a little while, and maybe not a huge drug problem, et cetera, then maybe they're going to tell their fellow homeless friends to, if they come in and do it, to lie and be more lie to be able to get served quicker than normal.
100%. And we've seen that. So don't use my language at all that you're homeless. You're not homeless enough, because you'll just come back with somebody else telling a different story. Don't use that language
can I
at
say
all.
something
Go
else?
ahead, Nick.
So with that, with all the questions that Lauren asked you to ask and getting to an access point, this is why I like to do them face to face, is because you can pretty much tell when they're trying to get around the questions and not answer correctly when you're doing this. I mean, I do believe in being straight up and letting people know, hey, no. And that's why you do the diversion first. Like, no, there's no point of us doing the access point because you just became homeless. And it's stuff like that. And I do believe in telling them the truth. But like I said, that's why I try to defer from doing phone access points, because then you're not really getting that one-on-one. And definitely be hard on these questions when you're asking these questions during that access point. That I need that date. I need that homeless date. You just can't say I've been homeless for 5 years. Just 5. Like, okay, well, give me a roundabout area. Let me get what's the closest time you could give me. Because you know when people are trying to get over or try to do it. So it's really, I know a lot of people don't like to do it. You're going to have to just, it's kind of being hard to help them. Like, the only way I can help you is being direct and on point with the questions that I'm asking you. And if I'm not asking you these hard questions, if I'm not doing it, then I'm doing you an injustice. Because then you're not going to get the assistance you need, and you're going to sit around and wait for it. So that's why I know Lauren pushes it and I push it a lot. That diversion and these hard questions and giving the hard answers is actually helping these people. Because if you give them just the soft answer, then they just gonna wait. They're gonna sit there and like, okay, well, I know the money gonna come later, and it's not. So you really, and I know a lot of people don't like, well, it seems so mean. It's not. You're just telling them the truth. I rather so, and I get it all the time. A lot of clients do tell me, I'm glad you just told me straight up. So now I know I got to do something else, because I can't sit here and wait. And I'm like, that's the honest way of looking at it. You're probably not going to get anything. But now we identify that you being homeless. This is what it is. You need to still try to move forward on your own. And they're like, thank you, especially the ones that come from out of town. And like, I want to get assistance. You're not going to get anything. And like, well, I called 3 different people and they never told me this. They just give me your number. I'm like, this is, just tell them. I hate to say it, you need to tell them, hey, this is it. You're probably not going to get nothing. But this is how the government deems us to work. So this is how it has to move, and this is how it has to work. All right, I'm done, Lauren. I'm sorry. I got my bandwagon.
Snaps. Thank you. Thank you very much. I mean, your experience is, it helps other users. It really, I 100% agree. And I've had that same conversation with clients that get me on the other line, and I'm saying, okay, well, where did you stay last night? And where have you been? And blah, 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 blah. Well, I just moved here. Here's the reality of the situation. Your homelessness and your previous, your homelessness, and I want to make sure that we are, I don't know if I included this point in the prior living situation and approximate date homelessness started. I know we talked about it in the PowerPoint, but for our out-of-town friends and visitors that come to our community, literally homeless, if this client had identified, as an example, this client had identified that they were in a, let's even say that last night they were in a place not meant for habitation. Well, how long have you been here? When did you get here? Oh, well, I've been living in my car since I got here last Friday. Well, that is the client's approximate date homelessness started. Or if we are creating the client and they are, again, if I had to create this client to give them this access point intake, if there is no verifiable homeless experience in our continuum that you can see, and you had to create this client to make this access point, then that is their date of homelessness. It's either the date they got here or the date you created them. That's the reality of it. We cannot account for clients' lengthy history of homelessness in Los Angeles County. If they are coming, there were multiple clients over the last 3 months that appeared in our system for the very first time to get a coordinated entry intake. And I wish that the person that was doing those intakes had that conversation that Nick did, because none of those people are going to be triaged ahead of clients that have long histories of homelessness in our community. Nick?
And one more thing, yeah, if you get that, I just been out here homeless for 10 years and I ain't talked to nobody. You know that with our hot teams been in out here for the last 5 to 6 years, there is no way that they haven't talked to a hot team or an outreach person in Sarasota County. So I express that a lot. So when I hear, oh, I just been out here and I ain't talked to nobody, where were you been out? You in Sarasota County or city? City. I said, so who have you talked to? Oh, I ain't talked to nobody. Then you know that that's not true, because we know cities out there every day. We know counties out there every day. You have talked to someone in outreach in Sarasota because of the outreach work that has been done. And we know the areas in Sarasota city and county where most of the people are at. Now, they say they've never been to Turning Point, so they never been to Salvation Army Manatee. That is very hard to believe.
Absolutely.
So that's what you really have to dig in. Like if they say, I just been homeless for 10 years, where are you at? Well, oh, I've been jumping from house to house. And then you let them know that's not homeless. That's couch surfing.
Yeah.
And it'll all been on like I said, those are the things you have to say while you're doing this, because that's where you're going to break down who's the chronic homeless and who's just saying something to try to get some government funds. And realize they have to move forward.
Thank you. Thank you. Your experience is vital to these trainings.
That's why I got on. I'm sorry, Lauren, I was so late.
No, you're fine. I might have to require you to attend these going forward once a month. Just because it's helpful to the system. I mean, Lucy and Avery, you guys know your clients that are out there every day. You know where they're staying. Ursula and Carmen, you guys work at Turning Points. Your agency provides so many regular services that it's unlikely that if a client is experiencing literal homelessness in that area of Manatee County, that either Lucy or Avery haven't contacted them or they haven't gone to Turning Points, just like what Nick said. You know, we're all creatures of habit, and the reason that we have these wonderful agencies like Turning Points and like the Salvation Army Sarasota or Salvation Army Manatee is to provide those basic needs for clients so that they're not starving. They don't have opportunities to get showers or to stay even on a mat overnight. You guys have these agencies that exist to provide these basic needs. So when we are creating clients in the system because they don't exist, that's typically a good sign that the client's probably new to homelessness, and to ask more questions so we can better treat, not to, get a gotcha moment or, create a barrier into entry in the coordinated entry system, but to have the realistic conversation with them and go back to what Nick said. This list is to identify yourself as homeless in our system. From there, it's really just a triage system, and we have to serve those that are hardest to serve first. Does anybody help? I love the dialogue. Centerstone, you guys have anything you want to add over there, or Carmen or Ursula? Okay. Well, with that, unless Brian and Brian, you have any final words, Aaron, Libni, I'm leaving you out because I know that you just started like last week. Do you have any final words, Libni? Any questions?
No, I just really appreciate hearing everyone's advice because I need all I can get. So I really appreciate hearing what everyone has to say.
Yeah, cold caller. Brian Overby is, and Brian Scott just started at Salvation Army Sarasota, so he's new like you. And Brian Overby has a long history of doing street outreach and diversion at Salvation Army Sarasota. Nick, very extensive. If you ever just want to cold call people and chew their ears off, that's what I did when I started. I was like, so what do you think? And then I tell them why they were wrong. Just kidding. So yeah, with that, I think we're good to go. If you don't already have the Access Point EDA, I will be adding it to you as soon as we're done with this call. And thank you guys all for being on the call and your participation, and have a wonderful work week. Please let me know if you need anything else. I will be sending the Access Point PowerPoint and intake instructions and recording of this as soon as it allows me to. So thank you guys very much.
Thank you, Lauren.
Thank you. Have a great week.
Thank you.
Bye.